Continued gluten ingestion is the most common and important reason for continued symptoms or non-responsive celiac disease. And of crucial importance is the nutrition consult. And someone who's experienced in celiac disease. I often see patients who are reluctant to see the nutritionist again because their first experience with being referred to a nutritionist was very unhelpful. Basically, they felt that they, even at an early stage, knew more than the person they were referred to, and they're often still just sent on their own to research which foods are appropriate. So the experience is really helpful and required. In addition to the initial consultation, follow-up is also important to make sure that the gluten-free diet is being followed, but also to make sure that they're incorporating good, healthy food choices and not becoming overly restrictive. And using other resources, local and national support groups, as well as the internet can provide additional assistance with questions. If a patient is adhering to a gluten-free diet, we often need to exclude other possibilities. Pancreatic insufficiency, a trial of pancreatic supplements can be helpful. Bacterial overgrowth, we do breath tests for bacterial overgrowth at the Celiac Center and find that there is a significant number of people that may have small bowel bacterial overgrowth and benefit from a trial of antibiotics, as well as lactose intolerance, fructose intolerance, other coexisting conditions, including microscopic colitis, autoimmune enteropathy. We can send antibodies to check for this. At this point, further evaluation is often warranted, and repeat upper endoscopy with biopsies for intraepithelial lymphocyte phenotyping. That's immunohistochemistry, staining of the lymphocytes, and flow cytometry to rule out clonal changes. And these are evaluations to look for the more unusual condition, such as true refractory celiac disease. A colonoscopy to rule out microscopic colitis and other colities. Abdominal radiology, which would include a CT scan or MRI enterography, again looking for other conditions, inflammatory bowel disease, malignancies. And video capsule endoscopy, as well as small bowel enteroscopy. Video capsule endoscopy is a relatively non-invasive way to visualize the rest of the small intestine. This is the picture of the capsule endoscopy, which contains a video camera, a light source, a battery that lasts 8 hours. It's about the size of a big calcium pill. And after an overnight fast, patient comes in the morning and swallows the pill camera with a glass of water and is hooked up to the monitoring system that you see, and the capsule camera transmits the pictures to the monitor, which is then downloaded into the computer, and it makes a movie. This is a typical picture from the capsule, and the diagram shows that when we read the capsule, it gives us the location of the camera as it travels down through the stomach, small intestine, and into the colon. It's a relatively safe, non-invasive test, and it's a good way for us to evaluate patients that aren't doing so well and rule out other conditions, lymphomas, polyps, ulcerative jejunitis. This is an example of what we see on a capsule endoscopy. This is a clip of a movie, and this is a patient who has celiac disease. The mucosa is very scalloped. There's a mosaic pattern, very cobblestoned. Takes a while to review these. A lot of pictures. These are other techniques that we now have that makes examination of the remainder of the small bowel much more doable. There's double balloon enteroscope, single balloon enteroscope, spiral enteroscope, which utilizes a spiral overtube, and a long enteroscope, and laparoscopy-assisted enteroscopy. We use the double balloon enteroscope and the spiral enteroscope. And this allows us to examine the jejunum and ileum and go to places often that are first identified on capsule endoscopy. So if you find an abnormality on capsule endoscopy, such as ulcerations or a polyp, you'd like to go down and biopsy these areas and see if this is something that is to be worried about. Is it something that needs to be resected surgically? You can tattoo it, and then the surgeon can laparoscopically resect it without having to do an open operation necessarily. This is just an X-ray that shows you how, when you're advancing the enteroscope, you're going through loops and loops of small intestine. Just a diagram of what a double balloon enteroscope looks like. It utilizes this two-balloon system to pleat up the small intestine and allows us to go much further than we've been able to do in the past. And this is just a little schematic of how we do this. And that's a typical view from an enteroscope of pretty normal looking small bowel. Again. So once we're examined the small bowel, we do that to exclude adenocarcinomas, lymphomas. You can, the other consideration for non-responsive celiac disease is refractory celiac disease. And it's defined as an initial or subsequent failure of a strict gluten-free diet to restore normal intestinal architecture and function in patients with celiac enteropathy. There's villus atrophy and crypt hyperplasia with increased IELs, which last for more than 12 months in spite of a documented strict gluten-free diet. People usually have persistent symptoms of malabsorption. Prevalence is unclear, but it's thought that it affects possibly 5% of patients with celiac disease, certainly a higher proportion of patients that are seen at tertiary centers for non-response. And in general, refractory celiac disease is divided into two types, type 1 and type 2, and it's on the basis of the phenotype of the intraepithelial lymphocytes. And that's the value of repeating the biopsies and doing the staining and the flow cytometry with the change in the markers as well as the presence or absence of a clone stratifying into these two groups. The treatment is still a gluten-free diet, but it has to usually incorporate some immunosuppressants in the way of corticosteroids in type 1, type 2 also, as well as other more stronger therapies such as chemotherapy and more experimental therapies that are being looked at, since the prognosis in type 2 is more serious and more poor prognosis. In summary, then, the most common reason for continuing symptoms is continued exposure to gluten. Nutritional support is essential to good patient care. In situations of poor response to a gluten-free diet, the diagnosis of celiac disease needs to be confirmed and other diseases ruled out. And additional testing may be required to rule out refractory celiac disease or other complications such as intestinal adenocarcinoma or lymphoma.